My name is Peter Giles. I'm the Jesuit priest and the director of A Faith That Does Justice. I'd like to just talk for just a moment about what we're doing tonight. A Faith That Does Justice is an interfaith organization that challenges people to experience God by living their faith intentionally in service to others. And we do this by showing how unjust structures marginalize people and by acting to help those in need. Tonight's discussion is going to focus on really raising consciousness about the topic of tonight, which is healthcare disparities. And with that in mind, I want to just kind of frame this in a way saying that healthcare disparities are issues that really tend to affect one part of our population over another. And some of these factors that contribute to this are people with lower income, people who live in overcrowded housing conditions, people who are frontline workers. And what's common to all of this is that many, if not most of these people tend to be people of color. So tonight's discussion will focus on healthcare disparities from a general perspective and then really seek to really look at this from more specific topics as we go through the discussion. So with that, then, I'd like to move on to really introducing our panelists. And I'd first introduce Dr. Margarita Alegria. Dr. Margarita is the Chief of Disparities Research Unit at the Massachusetts General Hospital and the Mongan Institute. She holds the Harriet G. Leonhardt and Lucille Sire Leonard Endowed MGH Research Institute Chair as a professor in the departments of medicine and psychiatry at the Harvard Medical School. And second, Dr. Thea James is an associate professor of medicine at Boston Medical Center and the Boston University School of Medicine. She also serves as the associate chief medical officer, vice president of mission, and director of the Violence Intervention Advocacy Program at the Boston Medical Center. And finally, but not least, is Maria Rosario Gonzalez Albuquerque, who is the Director of Communications and Immigrant Health at Healthcare for All. She has held multiple prominent positions at Spanish language media outlets and has served as the Community Education Manager at the Massachusetts Department of Health. So welcome to all our panelists. We're delighted to have you here, and we really look forward to our discussion this evening. So with that, as we begin, I'd like to ask all of our three panelists really to talk for just a brief moment or two about their own area of expertise and how they may be really looking at this tonight, the discussion on healthcare disparities. So first, I'd like to invite Dr. Margarita Alegria to really speak from her own perspective, from a foundational formation, really on racial injustice and its impact on the healthcare system. So Margarita, please.
Sure. First of all, thank you for having me here. And I'm really delighted to be with Thea and Maria Gonzalez and with you to try to address what I think is one of the most important issues right now. I started this area, unfortunately, 30 years ago when disparities was not really an important topic. It was very hard to get funding to look at the issue. I started first, I have to say, describing the issues of disparity, mainly in behavioral health. After a while, became frustrated that nothing was happening. I kept doing one study after the other, and things were not changing. If anything, things were becoming worse. That led me to decide that I needed to take a different, to pivot to a different area. And so what I did is I decided to do more service types of research that would offer and try to develop models of care for ethnic, racial, and linguistic minority groups. And that's what I've been doing for the last 15 years. So I'm delighted to be here. I've done, I really love to bring the voice of the community into co-creating what services should be, and really looking at the perspective of different groups of stakeholders in trying to make services that are equitable, scalable, and efficient for our populations. I'm going to stop there.
Okay, well, thank you very much. That's really very interesting. So second, let me ask Dr. Thea, would you you're really a healthcare provider. So really from your experience at the Boston Medical Center, let us please inform our audience a little bit about where you'd be coming from tonight.
Yeah, you're on mute. You're on mute.
Thank you so much. I'm honored to be here this evening with everyone on the panel, my co-panelists, and you know, the people who have invited us here this evening. And I'm an emergency medicine doctor by training, and I was saying to the group earlier, I've always wanted to be an emergency medicine doctor, and it became clear to me once I became one why I wanted to become one. But you know, as an emergency medicine doctor, if you just think about the kinds of things that show up in an emergency department, just imagine that. You can imagine that emergency medicine provides a unique insight into human nature, the human condition, and really all of what constitutes life. And I have found out that people arrive in the emergency department with all manners of emotions and things, you know, fear, angst, sadness, anger, despair. But as the provider, you get to be that person who can shift their perspective. And it happens just from listening to them and letting them know that you hear what they're saying and what matters to them. But that's something that I learned over time. And I learned that over time because people will always, and by the way, I should have set the context. Boston Medical Center is the largest safety net hospital in New England. And so, you know, I would see a very particular spectrum of human populations, and mainly from communities that have been historically disinvested in. And so there are narratives about people who show up over and over for the same problems all the time. And they're generally narratives that are blaming the person. But what I learned by asking people this one question, what would it take for this to never happen again? What I learned is that given any opportunity, barring mental illness or substance use disorder, people will not choose suffering. And so I learned that people have limited resources, and when they have limited resources, they cannot prioritize health. They just can't. They're just trying to survive. And so that learning that enabled me to do the administrative job that I do right now, and has enabled me to develop a very different lens through which I am able to see people and what it takes for people to thrive.
Well, great. You have a wealth of experience, and we look forward to hearing more. So finally, as an introductory statement, Maria, working at Healthcare for All, you're an advocate of sorts and reaching out to different people. So really give us a little sense of where you might be coming from tonight.
So I'm here representing Healthcare for All. And if you think about why Healthcare for All was even started back in the mid-'80s, it was really the result of health disparities and what was called at the time hospital dumping. And I know having Dr. James here, it's just very interesting because they were bringing a lot of patients to Boston City Hospital at the time, and they were uninsured patients, and they were uninsured patients because of healthcare disparities, but I don't think they were framing the issue as such at the time. And Healthcare for All was created as a campaign to help all those people that were being disconnected from care, that did not have access to health insurance and so forth. And I just think a way to describe why we are where we are and why Healthcare for All does the work that we do as advocates is that a chain is as strong as the weakest link, right? We cannot all be promoting a society when some of us are being underserved. And I'm going to use the term underserved. I'm not going to use the term weak, and I'm not going to use the term vulnerable. The communities we're going to be discussing tonight are not weak. In fact, they may be stronger than others. They're just underserved and underrepresented. And that's what health disparities is presented, is that barriers that makes them underserved and underrepresented. And that's why I'm going to flip the coin as well. And I'm not going to talk about health disparities and tackling these disparities. What I'm going to be talking about is why we have to promote health equity and why we have to promote health justice. So I think that's going to be my framing, and I'm going to leave it there so that we can keep talking.
Okay, well, I can hear your passion, and we look forward to hearing more. So For our audience, let me just explain where we're at. We're going to have now about a 45-minute discussion with our panelists. After that, we'll take questions that you are encouraged to submit through your chat box, and I'll ask them on your behalf, as many as we can. And then we'll end with really our panelists hopefully offering some potential action components that people might be able to think about or to take as going forward. And then we'll end promptly at 8 o'clock. So as I mentioned, we're going to start here now with a general kind of discussion of healthcare disparities. And I'd like to ask all of our panelists kind of the following question, that from a historical context that I think many, many people have been sensitized in the past year about healthcare disparities related to the COVID pandemic, as well as the Black Lives Matter movement and the obvious racism that continues to exist in this country. So with that in mind, maybe Margarita, I'll ask you to start off. Here's a general question. Can we have an elimination of racism if we don't have an elimination of white privilege? Are the two linked, that we must have a change in both for really racism to subside and for healthcare as well as other social disadvantages faced by so many people of color really be improved within this country?
So my answer to you would be that we can have both. We can have sustained white privilege with the racism that exists in this country. There has to be a disruption of power. I've said this before. The powerful, which in this country have been really a white-centric population, cannot continue to hold most of the power. I think this is completely a tragedy, because one of the things we know from studies is the powerful, if they don't share power, you actually create they have a blind spot, a huge blind spot that we have seen just recently in really acknowledging what is happening in this country. So for example, if you think about Black Lives Matter, about COVID-19, about the racism, the rampant racism, the immigration crisis that we've had, it just shows you the lack of understanding, the lack of compassion, but more importantly, the lack of really sharing power and sharing resources and the opportunities so that we can all benefit from society. So I honestly don't think we can have both at the same time. And I think one of the things we have to really think in this dialogue is, how do people that have usually held power understand they have to give it up? There has to be a disruption of power, and power needs to be changed completely. And organizations that have held power need to be disempowered to actually allow for a more equitable society.
Okay, thank you very much. So Thea, as a provider with a lot of experience of seeing very needy people, what's your take on this? You have to unmute.
You're on mute.
You know, I must not be a fast learner, but you know, I completely agree with Margarita. You cannot have both. I mean, clearly there's overt racism. You know, there's one thing in overt racism, but then there's also racism among the most well-intended people who just, you know, don't understand, you know, what's happening. And I think last year was the most common thing people said is they didn't know. You know, when all these things are happening, most well-meaning people are like, I didn't know. And so my first question to that was, well, you can predict outcomes from people based on demographics. I don't care what you're studying. You can predict the outcome. You know that people of color are going to do worse than everybody else. So if you didn't know, what did you think the reason was for that? I mean, did you think people just, you know, didn't care, didn't want to do better, not smart enough, you know, didn't work hard? I mean, it's so I think people have to understand how this all happened. And for me, it all when you talk about, you know, disparities and all these things, to me, these things are all the flowers you see above the ground. They are not the roots. You know, the roots have, you know, produced disparities. And, you know, that's, I agree with Maria. I wouldn't use vulnerable because people have been made to be vulnerable. And so when you look at things like, you know, and I'm going to be quick about this. In the 1930s, you know, back right after the Great Depression, when we were, you know, the economy was really, really bad. And our president was trying to resuscitate the country and creating pathways for people to build wealth. And he was brilliant because he created a pathway to the most common pathway to building wealth in America was home ownership because of the benefits of home equity. Brilliant plan, except at the exact same time, he created redlining. And if you lived behind red lines across the country, you didn't have access to that wealth building pathway because you couldn't get a mortgage. You couldn't indulge in the financial services because you were deemed a risk. And he asked housing developers to build all this housing for people. And they would subsidize them only if they agreed not to sell it to Black people. So right then you just create these two socioeconomic populations and these communities that do worse than everyone else. And that perpetuates itself to this day, which is why those communities mirror by maps the same communities where the highest rates and deaths of COVID occur.
Yeah.
So it's an economics issue here, you know, from my perspective. And until we're able to like address that so that you can create equity, mean that everybody, no matter who you are, can wake up every day and choose the path you want for your future. Until you do that, unobstructed by systemic structures and racism, then nothing will ever change, no matter how well-meaning people are, no matter how much money they throw at something that doesn't work. You know, to fill gaps versus eliminate the gaps, nothing will ever change.
Okay, thank you very much. Very interesting. And Maria, as a healthcare advocate, what would be your take?
So I think we've seen this issue evolved over time. When we talk about health equity, health outcomes, we were looking at different factors that play a role in health outcome. And a few years ago, we were smart enough to realize that there's so much more to health outcomes than healthcare delivery, right? It's not just going to the hospital. It's just not just having health insurance. You have all what people used to call, and I don't think people like it anymore, social determinants of health, right? You have nutrition, you have housing, you have in the environment where people live, their immigration status. And we were including racism as one of those social determinants of health. And that was a big mistake because racism is not the result of something, it's actually the root of all these inequalities that we've seen, like institutional racism, structural racism, interpersonal racism, that is at the core. And I like the visual that you were talking about, that it comes from the roots and then you have the flowers, right? And at the top, that's the health outcomes. And the health outcomes are actually a result of all the racism that we've seen. And that's where we are right now. We have to change the bottom in order to get to better health outcomes, but social determinants of health can be changed. They're not determined. We have the power to change that as well.
Okay, very nice. So let me follow up a little bit. You know, Thea, we talked earlier, and I'd like to follow up on something you said. You talked about hearing or reading a talk by Debbie Irving, who talked about this idea of, is being a good person enough? And I mentioned that because I think in a way, you know, you're preaching to the choir tonight. Most, if not all people listening here are people of a social conscience. They're people who really would like things to be better and would consider themselves to be decent human beings. And yet you mentioned this idea of being soul crushed. I'd like to ask you if you could just really expand a little bit upon what we talked about privately too, so that everyone might hear this.
Sure. As soon as you mentioned her name, my heart sank. So seriously, so our hospital hosted a webinar that Debbie Irving, who's an author, presented at, and she was talking about, she'd written something about I'm a good person, isn't that enough? And she talked about growing up in Winchester, Massachusetts, in a very liberal family, a very leftward leaning family of good people. And she said her parents really never said, you know, they were always, you know, on the side of people who had been disinvested in, but all around here, the explanations for why they were disinvested, what she would hear and things and see and hear, like she might talk about, you something happening to someone, there might be a person of color, whatever, and the parents might say, oh, well, they're a good person, but they just are not as smart. They're not smart enough. Or yes, they're a good person, but they don't always make good decisions, or they don't know any better, or they don't work as hard. And when I learned that, I mean, my soul was crushed. And I feel like, I guess I'm still not completely over it, because I felt it viscerally when you mentioned her name. And because I couldn't understand why someone would think that way. But then I'm thinking, it's a mindset. It's a cultural mindset of some sort. People don't know any better. And that's an example, I think, of racism in the most well-meaning people, who don't, they don't mean to be that way, but they just don't understand. They don't know the big picture. But I got over it. I thought I was over it, and I probably am mostly over it. But compared to where I was then and where, I am now is a big difference. But I learned something. And what I learned from that is that narrative is a very deep narrative. And that narrative is not going away easily. And it is something that we will have to be working on constantly.
Right. Yeah, your idea that what you're mentioning, the idea of racism, obviously there's overt racism, and maybe what you're referring to here, and a lot of people of goodwill, is a covert racism where they're not even aware of it.
Right.
And what would you say to this, that the idea that what really is necessary is that people take risk, that they move out of their comfort zones and into situations that challenge them to be more open to people of more diversity?
Well, I mean, but it's more than just being open to them. You've got to change your mind. You know what I mean? It's more than being around them. It's more than inviting them to dinner. You got to change your mind, about how you think about them, as human beings. So, it's just much more than that. And I can't tell you how many groups, even within this hospital, that have formed since last year, where they're reading all kinds of literature on these things.
Yeah.
It's almost like book clubs,
Okay.
Yeah, I wanted to follow on what Thea said, because I think we need people to change the narrative. It's just not to be there, but to actually make sure that they change the narrative. And that includes, raising the issue when we see it, because I don't think there's enough of that happening in policy making, in service delivery, in interaction, social interaction. So I think trying to make aware that people are using the wrong narrative, that's the narrative that we've had for many years, but that was a wrong narrative that we were fed, and people believed it. And I think it's still very palpable in our environment.
Okay. Well, let me move on to another question. Maria, in talking with you, you had mentioned this idea that given the way society is working, that there's fragmentation, that we fragment society into different groups, and it really leads to the deterioration of the wellness of society as a whole. Could you just kind of talk a little bit about that?
So it's because we categorize people, and this is when we do the work of health disparities, we have barriers that impact different segments of society. When we put things in silos, we're not communicating with each other. And this has to do with the racism work that you guys were mentioning. But when we talk about specifically healthcare, I think the fragmentation is not just the society, it's also the body. Like there's fragmentation when we talk about physical health, mental health, and oral health. We always say a healthcare for all, that the head is part of the body. And we tend to talk about going to see your primary care physician, but we don't talk about going to get your oral health or going healthcare, or going to get your mental health care services as well. I think that we do these fragmentations at two different levels. The societal fragmentation, in which immigrants are one group, people like LGBTQ people are another group. We're trying to segment people. What we need to do is to really look at all the needs of any of those groups and kind of serve all of them. And then we have this other fragmentation in which we actually forget that the head is actually part of the body. So that's how we think about this dual fragmentation.
Okay, very nice. Yeah, and Margarita, when we talked too, you mentioned that this idea that healthcare disparities, that it's really, if I'm understanding you correctly, that you talked about it being, in fact, more of a social issue than it is a medical issue. And if you could just kind of maybe elaborate on that a little bit.
Absolutely. I actually think that going back to the issue about fragmentation, I mean, there's great work that has been done in terms of how we value people and how we put our society makes very symbolic attributions of who has worth and who doesn't. And also, it also makes very clear distinctions to whom should the resources go or not. And this type of decision making that doesn't get sort of seen with a wider lens. I think the issue that we were talking before about how we need to look this with a wider lens and go more in depth to see who's getting benefit and who is not, and how we are not offering the same sort of things to different groups of people. And the labeling is very, very subtle. People have become very good at making these distinctions very subtle, but they're there. And in the social interactions that we have, for example, we call people certain names. We have code words of what it means to be valued or not valued that are very, very underneath, but they're very palpable. When we talk, for example, I was doing a study on socioeconomically disadvantaged neighborhoods, and I don't like using vulnerable either. But the youth actually knew exactly what code words were used for inclusion and exclusion. And that's, to be a youth and know so early on how you're included or how you're excluded, that's a terrible thing to do.
Okay. Well, what we're hearing here is obviously that there needs to be fundamental change in the way the healthcare system works because of the social fragmentation that has occurred as a result. Let me ask maybe Thea, the idea that is there a role model? Is there a system? Is there a country where this is being done, healthcare distribution, at a much more equitable level than it's occurring in this country right now?
Well, I can tell you by the data, there are apparently many, because we rank pretty low down near the bottom of the list among the wealthiest countries in the world in terms of healthcare outcomes. And on the flip side, we spend more money. We're at the top of the list for that. We spend more money in healthcare than any country on the planet, and we have no return on that investment because the outcomes are the exact opposite.
Great. And Margarita, from a structural perspective, what would you say to that?
Well, I would say that that's part of it, but I think part of it is, what we have allowed in terms of policy and where do we see our role. I mean, one of the areas that I would like to bring to the conversation is the importance of civic engagement and civic leadership of everyone like us. I think we've let ourselves down by not engaging in what's happening in our communities and not being part of it. And so I do think that part of what we need to do is engage in and get others engaged and do more of a social movement if we really want to have organizational change at not only at healthcare. I think it has to go with all these systems that intersect with healthcare, like the criminal justice system, like the education system, like the housing system, that are really part of the equation of why we're doing so poorly.
Mm-hmm. And Maria, your outreach to follow up on the idea of communities, you've been involved with outreach. So what would be your take on that?
Well, I think the example is really COVID-19, and we all know this, but I'm gonna repeat what happened during the pandemic, and we're still in the middle of it. Let's just not forget. But we know that the data from the CDC showed that Black and Latinx residents were 3 times as likely as white residents to contract COVID-19. This really shows where we're failing in the country. It wasn't new; it was just clear. All of a sudden, it was clear for everybody to see the health disparities were very real, and that there's something in this country that doesn't work. Of course, there are many things that don't work, but this was just a very clear example of a healthcare system that was not equitable. And it wasn't a surprise for many of us. It was a surprise for many, but not for the ones that do the work on the ground. So working with these communities, it was very clear. And we've been talking about the example of this community here in Massachusetts of Chelsea. It's a very diverse community, low income community, extremely underserved and underrepresented, but extremely strong. And I think they've shown that strength. Now they have their own vaccination site with the Chelsea Collaborative and Gladys Vega. So there's a way in which communities can be empowered to take on themselves like the work that, that they need to do, even though they should have been served better. But like there's a way to empower communities. But I think that is, so the civic engagement point that you were making, Margarita, I think that this is when it shows. An example with Chelsea, where a community where you had such a large number of people who were impacted, were infected, and also a lot of deaths, and they just decided to just, with the right leaders, to take it on themselves, to have access to testing, to treatment, and now to vaccines. We shouldn't leave it up to the communities. This should be a partnership between federal authorities, state authorities, local authorities. But I just wanted to give the example that there's a way in which we can empower communities to do some of this work as well.
Okay, thank you. Yeah, and Thea, when we talked, you mentioned this idea that the privilege of engaging people who come into the emergency room, especially people in need. And you talked at one point about whether it's generic, meaning many people are doing this, or one woman in particular who came back with the same problem over and over again. And you said the question is not so much, how do we solve our problem this time? But you talked about the idea of we need to go to these people and find out the conditions under which they live. So what can you say more about that?
Well, I think it's more about asking them, as you were saying, I personally don't need to know how they live. I already know how they live. You know what I'm saying? You know what I mean? I do think a lot of people don't, though. So one of the things we do is, I'll tell you 2 things, actually. One of the things we do is when the residents start here as new doctors out of medical school, we do an orientation around, and sorry to say the words, Maria, but determinants of health. And, so that they can start off looking at patients through a different lens, that they are understanding root cause and not taking on, because young doctors learn from what they're exposed to, and they're exposed to these pejorative narratives that, are just not good. And so, we have them looking through that lens. The other thing we do, and many different departments do this, is they take the interns on, take them on excursions, if you will, or trips into the community to meet people and that type of thing. I'll tell you something that we did even around COVID-19, for example, when the vaccination sites were being created, the first 2 vaccination sites that were put out by the state, when you looked at where they were and you looked at the communities that were most impacted by COVID, they were not near, they were not proximal to those places. Now, if you really understand what equity means, just think about that. The first thing you might think of when you're creating the sites is that even if you weren't thinking about equity, you might say, where did, most of the deaths and cases occur? We should make sure those places get vaccinated. But that's what I mean about, it takes a while. The narrative, you have to learn about equity. You have to learn about why things are like they are. It takes intentionality, And so one of the things we did was, we have a new vice president of community engagement and external affairs, and she convened all these leaders from out in the community. And we're doing different groups, but we did the first group long story short, we were just trying to engage with them and partner with them and have them help us to tell us where are the best opportunities to address, access to vaccinations and even hesitancy, addressing that. And we have set up 4, almost will soon be 6 sites out in the community, right where all the cases were, the highest rates of COVID and the deaths were. And so it's been, and it was easy, when I say easy, you just reach out, you go outside the walls of the hospital, to where people are and partner with them. They are very willing to partner with us. We just have to, medical education, I think, just really has to be redone and become relevant, because presently it just isn't.
Okay, that's interesting. Would you say that's true throughout the country, that are many people doing what you're doing, taking new residents and exposing them to the community intentionally, as opposed to just seeing them in the hospital?
There might be, I'm not sure. I can't really comment, but on that, but there might be.
Okay.
I mean, we've been doing it for about 5 years, so probably someone is doing it.
Okay. All right. Well, yeah, we're talking about COVID some. I'd like to segue a little bit into the COVID-19 pandemic. And I think most people listening tonight would know that there is tremendous disparity in the number of deaths. At least what I've read, that Blacks in this country are dying at 2 to 3 times the rate of whites, and that Blacks and the Latinx population in general are more likely to have lost their job or lost income as a result of the pandemic than whites. And I think another really significant issue is, when you think about it, the education of children. People from white upper middle class suburbs are really who have access to computers and internet. This hybrid education has gone much, much better than it has for people of lower income who might not have access and have parents who are really perhaps lesser educated and really more likely to be unemployed. So Maria, let me ask you, from an outreach perspective, when we talk about COVID, the effects that you're seeing and what you might have to, we might have to think about in terms of changing that. And I see you on mute. There you go. Okay.
So not only in terms of the education, this is the digital divide you're referring to. And I think the COVID-19 pandemic has showed us those disparities in a very clear way. As I said, you did say that they were more likely to get infected and more likely to die. And like Black and Latinx communities were, just hitting all the ratings during the last year, almost a year. I want to give an example of how this was being reflected in the community. We were leading a campaign to communicate with Spanish and Portuguese speakers right after March, because we were hearing from the hospitals, from doctors, that most of their patients only spoke Spanish, and some of them Portuguese, but most of them Spanish, because they did not have the information that was being shared. And we were very fortunate that our governor was like sending new messages every day. And we had information coming at us, but it wasn't getting to our community. So that was like one thing that was very clear to us. We heard from hospitals that most of their patients spoke Spanish. So we kind of took upon ourselves to educate, to send a message out of, protect yourself, keep the social distance. I like to say physical distance, because we can be socially connected and physically distanced, right? So keep the physical distance, protect yourself, wear a mask, all those things that were basic, that were not getting to the community. We just launched a campaign. We did all the Facebook platforms that you can imagine, used all the media outlets that you can imagine to get to our communities, and so forth. I was doing some trainings, and one of these trainings was with home health workers, people that work based in homes. And I was doing this training with the Dominican Development Center, and it was shocking to me that several people that I was talking to already had COVID, or were in the middle of having COVID, or had very bad experiences with COVID. Like one of them told me the story of their daughter going to the hospital, being pregnant and being ignored and almost not making it. And this is like what tells you, and I was shocking to me, because it was at the very beginning, and I was thinking, when am I going to hear of somebody who's actually had this, right? And it was everywhere. It was everywhere. Every training I did, every little, interaction I had, I found people that were being impacted, being infected, getting symptoms, getting very sick, knew somebody who had died. So I think that that's a big example of, the disconnect between some communities and some other communities, and how important it was to get to the right communities and that outreach, and how crucial it was.
Yeah, thank you. And Margarita, as leading the Disparities Research Unit, obviously you've been attuned to the disparities for quite a while. Let me ask you, what did COVID do to your people? I mean, did it heighten any sense of what's going on, or just make it, certainly much more apparent?
I think it's not only much more apparent, but the urgency of getting resources became even more. I think for example, we run some clinical trials for people in what's called the accountable care organizations with our groups, in community-based organizations. We do a lot of work with community-based organizations to take services to them rather than people to come to the clinic, especially people that are undocumented, that don't speak English. And what we found is the enormity of the disparities in getting access were tremendous. Not only what Maria is saying in terms of information. So we created in different languages information of where people could get the resources for the pandemic. But I think more importantly than that, it was the navigation that people were asking. Like, where, can you help me call this place? Because I can't get through to get eggs. And that's where we were able to have care managers that actually helped us connect. And this was not only in Massachusetts, I have to say. We were seeing even worse in North Carolina, where we, with our populations, where people, they didn't have where to send people. At least in Massachusetts, we had some places where we could send people to food pantries to actually get, different resources, like the issues of eviction. When we had people with evictions, we could get them to Healthcare for All. Let's connect you to someone there that could. So I think what it made, it amplified the need. I don't know what Thea would say, but one of the things I've been saying to my staff, I've been doing this work for a long, long time. Pretty much in the last 15 years, we've done a lot of the services. I've never, ever, ever seen the situation so terrible in so many dimensions. And this is people being, like Maria was saying, very creative, problem solvers, looking for resources. It's not what people paint out there. These are people that really have survived and look for ways of surviving and doing it effectively. It's just that the lack of connections to resources, it's so felt through across the board.
Okay, very interesting. And Thea, in being in the hospital, what did you see? Did you see a tremendous uptick in people of color coming in infected by this, as opposed to people who would be white?
Yeah, I mean, our hospital became a COVID hospital. 80 some odd % of the people in the hospital were COVID patients at that time. And, before it happened, we were collecting data every week. We were, producing data. And, before it happened, before the data started coming out from around the country, I remember just feeling so anxious about it. I just kept saying, where's the data? Because what it's going to show and you just want to see it. And so when it came out, I mean, it was just like a textbook kind of a thing for us. But when we did the data every week, we looked at everything. And that's why I'm saying it was like a textbook, because the majority of the patients came from these communities that are our catchment areas, and all of them are those that were historically behind red lines. The majority of the patients who came in had high school education or less. The majority of the patients had comorbidities. And I'm not talking about 70-year-olds, 80-year-old people with comorbidities. I'm talking about people in their like mid 40s, with comorbidities. And so it so much pointed to so many other things, like, you know, people who have lower income and lower education have worse health status. You know,
Sure.
it was just like a textbook kind of a thing. So it was a pretty sad time. And our hospital was the first one that tipped over in the city. The
Is that
first,
right? Okay,
oh
yeah.
yeah. We wound up having to transfer some people out one weekend because we were just filled to the rafters. It was
Okay.
unbelievable.
All right, let me shift to vaccines. You know, there is a lot in the newspapers or on the internet about the pretty significant distrust among people of color towards vaccines, and there's a historical basis for that. Maybe just say a word, if you would, Thea, about that, you know, going back to the Tuskegee Institute and things like that.
Yeah, I guess the first thing I should say is I was one of those people. And uh, you know, Tuskegee is one thing, Henrietta Lacks is another, but a
And
lot
maybe just explain the Tuskegee. There may be people who don't know what
oh
that
yeah,
is.
so the Tuskegee study was some experiments were done on people who were like migrant, like farming kind of people in Tuskegee, Alabama, and they diagnosed people with syphilis, but they kind of like wanted to see the trajectory of the disease if they did not treat them, if they did nothing. And you know, they allowed this disease to progress in people, just, you know, using them just like guinea pigs, just
Right.
experiments, you know, and
Without treating them. Yeah.
without treating them. Yeah. And you know, and so, you know, it became a big thing, but not a lot of people today even know of it or remember it even.
Yeah.
And so all those, you know, those are, you know, those are seminal, you know, events that happen. But there are also the other things that I mentioned, and basically in broad strokes, whereas people of color just never being prioritized in any way, always being exactly deprioritized and always
Yeah.
getting the worst. And then looking at what you see that happens on television, and you know, the police stuff and people getting away with this stuff, and then how you get the experiences you have in a healthcare system. You know,
Yeah.
it could be something as far back as Tuskegee, but something that happened 2 hours ago in a hospital.
Right.
You know.
But are you making any progress in terms of trying to change that mindset that the vaccine would actually be beneficial for people to take, given that there is distrust, and rightly so, from the past?
We're working very, very hard on that.
Yeah.
I mean,
Okay.
we have meetings all day on that. We have maybe 3 meetings a day on that in
Okay.
different groups. What turned me around was I'm on the mayor's health inequities task force, and we were having a meeting one day, and it was just before they did the most recent rollback. They've actually rolled forward now, but they had just rolled back. I think it was in November. And the thought that comes to my mind immediately with that is, oh my gosh, now there's, you know, people who won't be able to work, people who won't be able to earn money, won't be able to feed their families. I mean, and it just, because I could kind of understand, although I'm a doctor, I understand the science. I could understand why people would not want to close down, because it you know, it means that they can't take care of themselves and their families. And so I was just saying all this out loud, you know,
Okay.
and then the next 2 days I couldn't get over it. I just kept thinking about it. And then I finally said, well, you know, the only thing that's going to get us back to being able to thrive is the vaccine.
Yeah.
And I said, well, I will take the vaccine. And that's
Okay.
how it happened.
And hopefully others will as well, you know, with education and in the work you're doing. I'm going to shift now into Black Lives Matter, the impact of that over the past summer for many, many people. Let me just speak personally for a moment. You know, I really, I think myself, as a lot of people viewing tonight, as a white educated person, really felt that there is racism in this country. I was not denying of it. But to see George Floyd and some of the others visually on television being, in fact, murdered, had a tremendous impact on me. And I think it probably did for many, many other people. I know recently there is this, Elizabeth Warren and Ayanna Pressley are putting before Congress this Anti-Racism in Public Health Act of 2020. And the idea of that, as I understand it at least, is that the accountability in terms of healthcare, when people die, it's not necessarily recorded their race or their age or their economic situation. And as a result, a lot of this data is being lost that could be used to help people. Margarita, let me ask you if you've had any exposure to this or been in touch with the people involved, and maybe just say a little bit about that.
Yeah, I was invited to go now to a workforce that's looking at this issue of race, ethnicity. I mean, let's start by the tragedy that Thea was talking about, looking at the data. I couldn't believe that when we started looking at the data in Massachusetts, a place like Massachusetts, 43% of the cases, the race ethnicity was unknown. 43%. Can you imagine that? I found that like impossible to believe. So, I mean, we have to start getting data in real time because exactly, if we want to get resources to where it's needed for any public health event, someone in the question in the chat was asking, this pandemic is just one of them. We're going to have many, and we need data in real time. So I think getting good data is urgent. But I also think we need data in terms of, what is related to people being infected because of one, the types of jobs where they cannot work at a distance. Two, the not offering transportation that is safe and people can really go to care. Three, the types of jobs people have that do not allow them to physically distance. I mean, we need more information to be able to do better public health. And that, I mean, during the last 10 years, the public health system has been fairly depleted. And that's where I think we need to invest in not only Massachusetts, but nationally. So I'm very glad that they're doing that initiative. I think we need to collect better data for race, ethnicity, and
Yeah,
language, by the way, and language.
Yeah, exactly. The idea that this data hasn't been collected, I think, speaks volumes in itself, that it was not prioritized. And I think perhaps the issues of the last year with COVID-19 as well as Black Lives Matter is really drawing to the forefront that people have been left behind in terms of using data that could really be beneficial to people who could benefit from it. Given time, we're only down to about 5 minutes now of our conversation before we take some questions from the audience. I want to get to the government's role in this, and one that is on many people's minds is what the Affordable Care Act, which has been called ACA or the Obamacare, has been really pushed by many people. It has been criticized by others. So Maria, let me start with you. The benefits and the downside of any of this as you see it.
So the Affordable Care Act was based on the Massachusetts health reform that we passed back in 2006. It was a little bit different. It expanded some things, and it didn't go as far as we wanted in some others, for sure, but it was such a leap forward for the country. It really allowed millions of people to have health insurance. And the truth is that in 2016, 2017, there was this attack from the federal government to really roll back the Affordable Care Act. And there was this national outcry in which organizations, advocates, activists, just fought very hard. And I think that it was a success that we were able to keep the Affordable Care Act. They found a way in the back end to kind of dismantle some of the pieces and getting rid of it's technically the individual mandate and so forth. But I think that has been such a big accomplishment. However, now that we have a new administration, we see a lot of optimism because they're not only protecting the Affordable Care Act and Medicaid, both things, and they're also trying to expand it. They're talking about like increasing subsidies. They're talking about now they've just reopened the marketplace at the federal level. So this is, I think I feel more optimistic than I felt in a very long time. I think we were all traumatized by all the backlash and all the fighting that we were doing for the last 4 years. There's still a lot of room for improvement. The Affordable Care Act is not perfect, but it's definitely a step forward. And we're looking forward to, working with the administration to really improve what we have.
Okay, let me follow up by obviously the other side of this. There would be some in this country who would say they want the freedom to be able to choose their own health care and their own providers. What would you say to that in terms of weighing that the common good of all that many people are clearly being helped by the ACA Act, but there are people who really raise criticism that it's too restrictive.
Because there's not enough investment. It depends on how many programs, how many plans participate. In Massachusetts, we have more options. In some regions of the state, we have more options for people, residents of those areas. The more investment, the more plans that participate, the better. If you have a government that's trying to actually dismantle the law, it's impossible that they're going to invest in having more plans. They're going to do the opposite. So there is room for improvement, and I wish there were more plans participating, specifically in rural areas. But it doesn't depend specifically on the healthcare providers per se. Those are negotiations between insurers and providers that have to take place for the insurer to participate in the marketplace and to cover the provider that you want. So this conversation is actually way deeper than it sounds. When somebody says, I want to pick my provider, well, when you have private health insurance, you're probably not going to be able to pick your provider. And you know why your provider may be part of your plan is because the reimbursement is there. There's money behind it that's going to pay for that provider. So this is a very, very deep conversation.
Sure.
Yeah.
Okay,
And
Thea, obviously you're seeing a lot of people who would benefit from the ACA, and what would you say about this?
Well, I would say more people, would have access, to healthcare.
And that has been proven. I think there are more people who have gotten access because of this, despite its limitations.
That's exactly right. And, I feel like there are even, and obviously when people have, better healthcare, I mean, it's one thing for, to focus on their healthcare. But, again, I will also say that we should also have a broad view on this to really also understand why some people are where they are in healthcare, in terms of why they have these comorbidities and things like that. And I just think it's an opportunity to create an investment, that we actually get a return on. So we don't use the dollars to do a more elaborate way of just filling gaps that people have versus taking the opportunity to eliminate these gaps.
Okay, very nice. And Margarita, the idea of Medicare, Medicaid, where do you see this in terms of from a structural perspective as a help to people in society, or is it being as effective? Is the government doing enough with that, or does it really need to be improved?
yeah, so I do think both Medicaid and Medicare can definitely be improved. Let me start with that. However, I think Medicaid is an amazing program, an amazing program. I work in the area of behavioral health. However, I don't think for certain areas, the reimbursement is sufficient. We know, for example, with work that has been done, that if we were able to pay more, like we pay more for Medicare for certain providers, we would be able to reduce the disparities in primary care by 2/3. So there's ways. The subsidies in Medicare are not as good as the subsidies we have in Medicaid. And that's an area where we could do a lot more in terms of making sure that people have subsidies in Medicare. So when they transition, they don't lose those subsidies. So there's ways we could make the plans more effective, but going back, everyone wants a program that gets you to go to any provider, to whatever. Even in private insurance that we have, we can go to any provider. So people have to have realistic expectations that any plan is not going to be the perfect plan for everything you want. But it, like Thea said, the Affordable Care Act really expanded the benefit package dramatically and lowered copays. So there's great work by Ben Summers showing not only did it include access, it improved access, it improved quality, and it improved outcomes, which is very hard to do.
Okay, and just so maybe not everyone understands, I think, is it fair to say Medicare, we're talking about access to that at 65 and older, whereas Medicaid is really targeting people of lower income to help them that way. So there's a difference that way too. And Medicare would be a federal program, and Medicaid, I think, is often controlled by states. So, okay, very interesting. Thea, do you want to say anything about that from your perspective in the hospitals?
About Medicaid and
Medicare, Medicaid, yeah.
Well, I honestly, I was listening to what Margarita said, and I have a little bit of a perspective on it that's a little bit different, and it's more pertaining to us being a safety net hospital.
Mhm.
And we get less money on dollars than other hospitals do, from these insurers. Like maybe, I don't know, 60 cents on a dollar, versus what others get. And so, I have I have a little bit of a perspective on it, but I think there's room for all of them to improve. And, I guess were it not for Medicaid, a lot of people would not be, would not have health insurance of any sort. But I do believe that all these insurers are not, have an opportunity to get a much larger return on the investment. That is huge dollars that get invested in those insurance, in Medicaid and Medicare. And I just think that there's room for improvement in those areas. I mean,
Okay.
without question.
All right. Well, that maybe brings us to the end of our personal chat here, people listening, and we have had some questions come in, and one of them is, it has come up, I wasn't able to ask it, but I will ask it now. It's the idea that if we talk about remedies in healthcare disparity, there's a lot that has to happen, as we've talked about, that it's a social issue, but also if we talk about the hospitals themselves, that any of us who've been in hospitals, and certainly in the Boston area, what you do see is a pyramid that people at the top of the hospital structure tend to be white. People at the bottom of that structure, and by that I mean physicians and nurses, people at the bottom of that structure, people who may be doing more service-oriented jobs, are people of color. And yet, Maria had mentioned this too, that people come in, may not have command of the English language, and that their interpretation is not, there may be someone who can interpret, but they may be white educated people who speak another language, Spanish or French or something, but they don't necessarily understand the culture, so that the culture of these hospitals have to change. And one question that just came in is the idea, how do we educate hospital personnel, or how do we change the mindset within hospitals to be more culturally diverse? So let me start with Maria on that, if you might comment.
So that is a great question. The truth is that many hospitals already in community health centers and clinics have community health workers. And I think I just love the community health worker system, because they are people from the community that have that cultural connection, that speak the language and so forth. We also have, of course, interpreters and so forth. But I just think the community health worker is that link with the community. And I mean, there's many other things that we can do, obviously. The more doctors that we have that speak the language, I think that there's an increasing number of physicians that are people of color and that may speak other languages and so forth. But I think relying on these navigators, on these community health workers, it's a great starting point to address some of the disparities at the community level. Okay, I don't know if Margarita or Thea, if you are, Thea, you probably work with community health workers. I just love them. I think that they do an amazing work.
Yeah. Thea, let me ask you, healthcare workers is one, but being a physician, we've in recent years, we've heard the concept of the feminization of medicine, that there are many, many more. I mean, medicine is becoming 50% or approaching, the med schools are 50% women at this point. When I was in med school, which would be maybe 40 years ago, it would have been about 10%. My father was a physician, and if you go back another generation, it was a token woman. But my question then becomes, what's the colorization of medicine? Where are we at in terms of people of color in med schools being formed to change the dynamic that currently exists. Do you have any sense of that?
Yeah, I mean, and most people who have D&I departments and things, when I say D&I, diversity and inclusion,
Uh-huh.
they have most medical schools and hospitals have these D&I departments. And what they use is intentionality, to create a more diverse staff of every place throughout the hospital, and including, the school, the residencies, and the workforce, and that type thing. And once again, it's one thing to, as they say, invite someone to the party, but they also have to be able to dance. So, these people, and as you say, bringing these residents in, more diverse people, but you also have to create an environment in which they can thrive. And so you have to you have to value what they can bring. And sometimes you might not know what you don't know, but you have to trust someone who does know to create an environment where they can sit at the table, make decisions, where they can become leaders. And it's one of the things I've been telling medical students more and more. You have to become leaders. You have to be the people. And I know it is, maybe a little cliche or whatever to say this, but you have to become the change you want to see. You should just, be leaders. And so it's intentionality is what I would say.
Okay, very interesting. And Margarita, from a structural perspective, the idea, another question came in about the idea of perhaps the medical institutions. How do they go about reaching out to the community organizations to get them to invest, both financially as well as in terms of expertise or people, to be able to make this a more equitable system, the healthcare?
Yeah. I'm going to talk about the institution I know, which is Massachusetts General Hospital. One thing they're doing is now they decided to make everything in the hospital is being bought by people from the community. So they're investing in everything that is a purchase, all the services, everything to be bought by people from the community as a way to make sure that we are helping the communities that surround us, meaning communities of color. So that's one thing. But I honestly, I'm gonna, bluntly say we have not done enough. I think we need to do a lot more in partnership with communities. We've had Joan Reed that has done a lot of work, and Joan in the community. We have a community aspect at MGH that has been very successful for aging, for example, for partnering for Chelsea communities with all the communities like Chelsea, Revere, East Boston, Charlestown. But I think we need to do even more in terms of academic and partnerships with community to try to bring more of the resources back and forth. And also, I really think that one of the things we never talk too much about is the community really being the input agency that tells us what's needed and how to do it best.
Uh-huh.
I think we need a lot more feedback loops from the community back to the institutions.
And Peter, one of the things I would add on to what Margarita said is MGB, as well as Children's and Boston Medical Center, are 3 Boston hospitals that are members of a national collaboration of now 60 hospitals called the Healthcare Anchor Network.
Uh-huh.
And their goal is to increase more inclusive, sustainable local economies through hospitals being intentional about how they make decisions in hiring, investment, and procurement.
Interesting. Very interesting. I didn't know that. Very interesting.
Yeah.
So here's another one that came in. Did you want to say something, Margarita? Go ahead.
No, I just wanted to say it's a big change. This is, more recent, but it's going to have a big impact in making sure that we're inclusive of raising everyone up. And the other thing I'll say is that the hospitals have really committed themselves to raising the salary wage, making sure that we, especially for people living in Boston, which is so expensive. So there's lots of movement that is happening to make sure that we walk the talk
Yeah, easier said than done, but I think you're probably right. Another question that's come in is the idea of, Thea had mentioned this, that the US healthcare system is not presently very efficient, and yet it's probably the most expensive in the world. So a question came in is, how do we control this? What are some steps that can be taken that, and it specifically mentioned, ACA or the Affordable Care Act or Obamacare as being quite costly to the taxpayer?
So as an advocate, one of our goals is to really bring costs down. I don't think the right way of doing it is cutting the Affordable Care Act, more the opposite. I think we're saving money by ensuring that people have access to health insurance. What we need to do is bring the costs down of, for example, prescription drugs. They're still unaffordable for people. And I'm going to talk from the perspective of the consumer. What is still not accessible for people, what is not affordable for people. So prescription drugs are still out of reach for many. We have hospital costs are very high, and then insurance costs are still very high as well. Many people cannot afford premiums, deductibles, or co-pays, and so forth. And that plays a role in them making decisions about their health. That is a country that has a system that doesn't work, when people have to pick and choose what kind of healthcare service they can get because they cannot afford it. Or somebody who's diabetic not being able to afford insulin. That is not cutting on the Affordable Care Act. The Affordable Care Act will ensure that the person has the insurance that's going to allow them to afford the insulin. So let's just find the right places where the cost has to be brought down, right?
Okay. Now here's a final question. We've had a ton of questions come in. I can't get them all asked and answered, but I apologize for that, but we are running low on time. But here's a final one. A question came in about the idea of, we had talked about this. There are many people of goodwill. We can argue whether they're doing good, whether that's enough or not. But the question was really, and it's common, someone who really would like to see an end to racism, that they're willing to give up some of what do we call it, privilege. What do you say to a neighbor? What do you say to a friend? What do you say to someone at work who really is, whether overtly or covertly, wants to maintain very clearly white privilege in society and not very willing to give much up and not very sensitive to what's going on right now in terms of Black Lives Matter? Thea, let me ask you that first to start.
Well, Peter, as a Black person, I don't know what I would say to a white person. I'm not sure they could receive it from me, quite frankly. They may be able to better receive it from someone else, but I would just want to, ask them why? And, what would it take for them not to feel that way? What would it take for them not to want to hold on to their privilege? Because it feels like people feel like to give up something, they're going to lose something.
Yeah, well, I think that's exactly it.
Yeah, and
fear.
And it's not really that. Yeah, it's a fear in some way, and it's not. I mean, they're not going to lose anything. They're not going to lose anything. They'll lose their fear, if they just try it. But yeah.
Okay. Well, let me say that this has been a wonderful discussion, and I want to move into our third phase. And I thank our panelists for all of what they said. And now we put them on the spot a little bit, that in this third phase, we just want to really ask as a lead-in. In March, we're going to hold a workshop where we really talk about opportunities to act upon what we talked about tonight. And a Faith That Does Justice as an interfaith organization, I talked in the beginning, part of our mission is to raise consciousness, to educate. The other part is to ask the question, how can we possibly walk in solidarity with people who are struggling, who are not being given a fair share of the goods of God's creation? I'd bring to light the idea that most, if not all, religions of goodwill would speak of the idea that human rights and human dignity are not state-given, they are God-given. So with that in mind, I'd like to ask our panelists to take a couple of minutes each, and really, if there's anything from this discussion that maybe you can leave us with, that a person of goodwill is asking, okay, this has been a beautiful discussion. What can I do personally? Is there anything I can do, whether it's alone or in combination with a community, be it a church group, be it a civic group, be it a larger organization, a nonprofit organization? So Margarita, let me start with you. If you have any thoughts you might leave people with as we use this as a lead-in to our workshop in March.
So let me start by saying I'm a big believer in social cohesion, social interaction. So the first thing I would say is I think I actually, responding to that question that you had before, I do believe on talking not to people that are the choir, but actually bringing in people that have very opposite positions from me. And then having a dialogue that shares ideas of both ways. I mean, I think the fear that Thea talked about is really modifiable. I've seen people change quite dramatically in exchanges, both with clinicians that we have worked to change how they feel about giving up power, but also with people that feel very strongly about not giving their power or not seeing why they should give their power, having a different composition. But I actually think that dialogue is one important thing, socializing so that it's not in a judgmental way, but actually it's more on changing the narrative, bringing people with examples that actually show the importance of why. Like, I like the idea of taking people over to places. I have to say, I actually came from a very privileged family, but actually did a lot of public health work and had to go to communities and visit people. And this was people in poverty in Puerto Rico. It really changed completely how I felt about things. So I think there is a way to interact by making that connection, that human connection with the people in those communities.
Okay, very nice. So the idea of going to people, however that's done, would be, it can be personal, it can be in a group as moving
Right.
to people.
Right.
Okay, Thea, what would you leave us with tonight?
Well, I think I would start off by asking people to ask themselves, what is your narrative? You know, ask yourself, what is your narrative? Like really look inside and ask yourself that. What is your narrative? What has it been? What about that are you willing to change? You know, and are you willing to change that? And looking at even where you might see something you don't like, you know, where you feel like you might be complicit, you know, inadvertently. And I think it's a good start right there. And then I would also say, you know, I'm a little bit biased towards altering life course trajectory for people, you know, because as I said in the beginning, I am so sort of bent toward economic mobility and those types of things that can free people from where they are. And I would say, you know, if you are a person who has an opportunity to do something like that, like if you are a business owner or, you know, what are your hiring practices? Think about that. You know, what are your policies in your organization? Like what might you may be able to do that would give a person an opportunity to alter their life course trajectory. I've seen a couple people do that actually. I've seen that. They bring, you know, a young person that they just sort of like take under their wing and bring them into, you know, their organization. I've seen that happen quite successfully, I might add. And so
so mentoring, I think maybe you're saying mentoring.
Yeah, and mentoring with like not setting low bars for people, because wherever you set the bar will become a self-fulfilling prophecy. And where you set the bar has a lot to do with the narrative. You know, if you think, you know, I always say to my colleagues, even my residents, when they want to think of a discharge plan for a patient, and I tell them, well, you know, just ask yourself, would I do this for myself or my family? And if it's not that, then you're probably not choosing the right thing. You know, so I just simple things like that that just don't necessarily come to mind because of that narrative. You know what I mean?
Sure. Okay, thank you. And Maria, how about yourself? Leave us with some words of wisdom.
So I talked about community power. I'm gonna talk now about individual power. Okay. We have power to change things, and there are ways of doing it. And we're gonna be talking about this in the workshop, so I hope that people join us. But at Healthcare for All, we really advocate for consumers. And I was trying to like list some of the issues that we've been trying to address: the affordability issue, like the fact that prescription drugs are out of touch, the fact that people cannot afford their medical bills, their co-pays, and so forth. Access to dental health is still an issue in Massachusetts and in the country. And at Healthcare for All, every year, every legislative session, we pick out which ones are legislative priorities and what are the things that we want to change. We can change this system in the long term. And I know Margarita was alluding to this, and Thea too, like we need to really reform things, but there are things that can be changed and should be changed and can no wait. And that's when we actually have power. You can advocate, you can call your legislator. Your voice as a constituent has a lot of power. And I'm going to leave it at that because I don't want to tell them how to do that, because that's when they have to attend the workshop.
Okay, well, that's a good enticement. So thank you very much. Okay, anyone else of our panelists want to say anything before we adjourn for the evening?
I want to
Okay.
say thank you. Thank you so much.
All right, well, let me thank all of you,
Thank
Margarita.
you so much.
And Thea and Maria. I think this has been a wonderful discussion. I think in many ways, I think we've accomplished what we've set out to do tonight, which is to raise consciousness, to open people's minds a little bit to the reality that this country has a ways to go, not only in terms of healthcare, but in terms of social issues that Margarita mentioned, Thea mentioned, and Maria as well, that we need to be who we claim to be, and it's going to only happen. I would believe personally, as you all, I think, agreed with the idea that white privilege has to be changed, has to be given up if we are going to put or make significant impacts in racism in this country, which COVID-19, as well as the Black Lives Matter movement of the last summer, has made very evident to, I think, anyone of goodwill and people of faith in particular. So I thank you all for your input. You've been very educational for all of us tonight. And I want to end by saying that I believe we have a date for March 23rd, our workshop. It'll be a Zoom conference as we're doing tonight. If you're on our email list, you will be contacted about that. It will start at 7 p.m. I believe it will go just for an hour. And the idea of that is really now to take the consciousness raising of tonight and to try and put a heart, hands, and feet on it, that we can act upon living our faith in action on behalf of all God's people. So I thank you all. And for those who either speak Spanish or know someone who speaks Spanish, I want to also make people aware that this Saturday at 10 a.m., we're going to have a workshop led by Sister Barbara Gutierrez, who will talk a little bit about our Lenten experience for those who experience Lent, about what we might do to try and live authentically as people of faith. So I'll end with that. Again, I thank everyone. I thank our audience for participating with us tonight, for your questions. They're excellent. Sorry I couldn't get to them all, but we ask you to please keep coming back. And if this has any meaning to you, please let people know about it. This video will be on our webpage. It'll be available for people to use. And we ask you, if it resonates with you, to please disseminate it so that we can continue to educate about the reality of racism in this country, of healthcare disparities, and all of the social issues that follow from it. So thank you very much. And I'll give you a round of applause because you can see me, but I asked our audience to do the same at the same time. So thank you very much and have a great evening. And we hope to see you all again soon.